Yeah, hello everyone. My name is Samuel. I am the AIMS HESA Academic Educational Board Chairperson. Today I'll be a facilitator for Respiratory Pharmacology. So let's delve into it. We'll be looking at the overview of the respiratory system, then we talk about bronchodilators, and then since our main focus is on asthma, most of these agents are the ones that are used in the treatment and management of asthma. So we have anticholinergics, metazantines, anti-inflammatory agents, leukotriene modifiers, and then we also have monoclonal antibodies and mast cell stabilizers. So let's look at the function of all these agents in the management of asthma. Bear with me. Okay. Now, we know that the respiratory system is made up of two parts. We have the upper respiratory system, the lower respiratory system. The upper respiratory system is made up of the nose. So from the nose pass to your nostrils. Then we have your pharynx. There are different divisions of the pharynx. Then continues down into the larynx, which is our voice box, and that is the upper respiratory system. The lower respiratory system continues from the larynx, so we have trachea, then we have the bronchus. There's a primary bronchus, and then it branches into secondary, and then we have our bronchus here, and the bronchus will end in sacs called alveoli, and so for the lower respiratory system, we have from the trachea to the alveoli. Now, this respiratory system, the airways are made up of, they are lined with smooth muscles and mucosa and then cilia. Now, these are the smooth muscles that control the um, airways opening, and then they also contain cilia that helps in the trapping of foreign bodies and dust particles. All right. Now, the most important ligaseous exchange occurs at the alveolar capillary interface. This is the alveolus, and wrapped around it is a tuft of capillaries which return carbon dioxide from the tissues, and then that is where carbon dioxide will diffuse and then move and breathe out when oxygen that has also been breathed in would also diffuse into the blood and transported as hemoglobin to the tissues for cellular respiration to occur. All right. Now, these smooth muscles that you mentioned are under the control of the nervous system, specifically the autonomic nervous system. Now, the autonomic nervous system is made up of two parts. We have sympathetic nervous system, and then we have the parasympathetic nervous system. With respect to the respiratory system, the sympathetic nervous system, which is the fight or the flight response, is bronchodilation. In fact, if you should encounter a lion right now, you would want to breathe in, you breathe fast, fast, fast. What it means is that your airways open up for the air to enter, all right, and that is under the sympathetic response, and this is due to the beta 2 receptors. All right, beta 2 receptors, and we have the parasympathetic nervous system, which is also with regards to M3 receptors, and that one too causes constrictions. That is, the airways would constrict or would narrow in space. All right, so it makes air entry very difficult. In asthma patients, we don't want the airways to be constricted, we want the dilation. And so what do? We need agents that will help us in bronchodilating the airways, and then we need agents that will stop the airways from bronchoconstriction. Okay, now these are things I want you to take note of. The parasympathetic nervous system mainly is associated with this neurotransmitter, which is an acetylcholine. Okay, so whenever we see acetylcholine, then it means that the airways are going to be what, bronchoconstricted. We also look at leukotrienes, as in the case of NSAID or aspirin-induced asthma, and then histamine. Okay, now the sympathetic nervous system too is associated with norepinephrine. So if you see norepinephrine in the airway, then we want to relax the airway, or we want to bronchodilate it. Okay, there is also non-adrenergic, non-cholinergic nerves that modulate the tone of the muscles. So we have the VIB and then NO. Now, what happens in the case of asthma is that asthma is a chronic airway inflammation, and so in asthma there is airway hyperresponsiveness. What happens is that it is a reversible condition. The airways are inflamed, and the inflammation of the airways is due to attacks from maybe an antigen or an allergen mostly, which is the case. And what happens is that the inflamed airway tend to constrict the airway, and when the airway is constricted, it makes air entry very difficult. And so in this case, the individual will try to respond to the inflammatory process by wheezing, coughing, dyspnea, chest tightness, and hypoxemia. All right. Sometimes too, between attacks, some people can be asymptomatic. They will not come with any symptom. But then when they are having an asthmatic attack, the airways are very, very narrow. So the goal is that we want to dilate, we want to open up the airway. All right. Okay, let's move on. So asthma comes in the various subtypes. So we have atopic or extrinsic subtype. This is the most common subtype that we have around, and this is due to type 1 hypersensitivity. That is, it is IgE mediated. We will look at that in a jiffy. And then this is triggered by allergens. So most people with asthma, you will see they have dasmites, pollen, pet dander. Most of these are things that will trigger the exacerbation or asthma attacks. All right, it is very common in children with a history of eczema or allergic rhinitis. So you will want to take note of this for your exams. Then we have a non-atopic or intrinsic asthma. This is mostly due to viral infections like influenza, and then stress-induced asthma too as well. Okay, this is very common in adults. Now, when do we say someone has a status asthmaticus? Status asthmaticus is when there is severe unremitting bronchoconstriction. So the bronchioles are constricted, and so the airway is very, very narrow, and nothing is causing it to open up. The agents are not working. In this case, the patient has a status asthmaticus and it's a medical emergency. You need to start your bronchodilators ASAP. Then we have NSAID-induced asthma. So when we talk about NSAID, let's talk about pain. We have what we call the arachidonic pathway from your pathology. Now, the cell membranes contains phospholipids. Now, there is an enzyme called phospholipase A2 which will break down the phospholipids of the cell membrane into arachidonic acid. Now, this arachidonic acid is acted on by two enzymes. You have cyclooxygenase and then we have 5-lipoxygenase. Now, these two enzymes have their own functions. Now, the cyclooxygenase we have about two of them. We have COX-1 and COX-2. All right. Now, the goal is that they want to produce ultimately thromboxanes and then prostaglandins that would help in the causation of pain and then inflammation. And then the goal of the lipoxygenase pathway is that we want to produce like leukotrienes, and this is what is going to help us in the production of what bronchoconstriction. These ones tend to trigger asthma. Okay, so we don't want leukotrienes. If you remember from the previous slide, we don't want leukotrienes in the management of asthma. So what do we do? When you give an NSAID, what happens is that this NSAID could be ibuprofen, it could be diclofenac, and all the other agents that we know of. We have selective COX-1, they have selective COX-2 inhibitors like celecoxib. These ones tend to block the cyclooxygenase pathway in the sense that we are not producing any prostaglandins. And then when this happens, what means is that the burden is going to be on this enzyme, the lipoxygenase, and so we'll be producing more of the leukotrienes because we've blocked the cyclooxygenase pathway. So in this case, because we are having a lot of leukotrienes, this is going to cause a lot of bronchoconstriction, and that is what leads to what we call NSAID-induced asthma. And so we want to give agents that would block this pathway as well. And so once we do that, we will not have any leukotrienes for bronchoconstriction to happen. And some of these agents are xylutine. So xylutine blocks the 5-lipoxygenase pathway. It blocks the enzyme itself. and then we will not produce leukotrienes. What if we have leukotrienes already in our system? Leukotrienes bind to receptors, and so we have drugs or agents that would also block the leukotrienes from binding to the receptors. And so these agents, montelukast and the zafilukast, which are the Lucas drugs, bind to the receptors to prevent the leukotrienes from binding to the receptors. Okay, so we have NSAID-induced asthma. These are bronchoconstrictive, and they are often part of what we call the Samtez triad. So we have asthma with nasal polyps and then aspirin sensitivity. Okay, now let's look at the immunological pathway in atopic asthma, which is the extrinsic asthma. There are two pathways, there are two forms. You have the sensitization phase, and then we have the re-exposure phase. So let's look at it. If you inhale the pollen, it could be an animal dander or it could be any other form of allergen. These allergens contains antigens. The antigens are presented on antigen presenting cells, and in this case is the dendritic cell. Okay, dendritic cell serving as an antigen presenting cell is APC, would present the antigen into a helper T2 Th2 cell. So we have the Th2 cell here, and so this antigen will bind to the Th2 cell. Now the Th2 cell will intend to produce some mediators, that's interleukin 4, interleukin 5, and interleukin 13. When it is interleukin 4 and interleukin 13, what happens is that we tend to um, activate antibodies, and these antibodies are the IgE antibodies. Okay, so interleukin 4 and then IL-13 leads to the activation and production of IgE antibodies. All right, and then the IL-5 will lead to eosinophil recruitment and then the activation. So we are looking at eosinophil activation here. Now, what happens is that once we have this pathway, when we have IgE antibodies being produced, the antibodies contain subunits, and this the tail of this Y antibody is what we call the Fc portion. So the Fc subunit of this would bind to the receptor of what we call a mast cell. All right. Now this mast cell, when we have antibodies binding to it, is called primed mast cell. So we have primed mast cell here. Now this is in the early phase or the sensitization phase of the asthma. All right, so we have primed muscle and then eosinophil activation here. Now, in the late phases, what happens is that when we have repeated episodes of the antigen, then the IgE antibodies would tend to I want to use the right term, they will tend to cross-link. Okay, they will cross-link with the mast cells, and the cross-linking of the IgE antibodies with the mast cells will lead to mast cell degranulation. Degranulation is that the mast cell is going to burst, and then once it bursts, it's going to lead to the production of a lot of foreigns. All right, and these are notable among them is that the production of what leukotrienes and histamines. And what does leukotrienes and histamines do? They tend to cause what? Bronchoconstriction. Okay, so in the management of asthma, we don't want this mast cell to be primed. We don't want the formation of these antibodies. We don't want the activation of the eosinophils. All right, because the eosinophils would tend to release granules. We will look at that here. So this is in the immediate phase when we have repeated exposure that the mast cells will burst open, and then we get a lot of products. Notable among them is the leukotrienes and the histamines. Now, in the late phase, rather than these leukotrienes and histamines causing bronchoconstriction, they tend to cause bronchodilation. And so this bronchodilation is going to lead to the recruitment of eosinophils. Now, once these eosinophils are recruited, they tend to, they tend to produce their major weapon, and their major weapon is what we call the major basic protein. And so this major basic protein is what is going to help the eosinophils in the production of what? Inflammation. So the airways become inflamed, highly inflamed. So the inflammation here is going to be enhanced in the late phases of what? Asthma. And then in this stage, the patients tend to struggle or gasp for air. All right, we don't want to get to this stage, so we want to arrest it ASAP. Now, like I said, One thing we can do is that we can use what we call cromolyn sodium. This cromolyn sodium tend to inhibit the prime mast cell. So we are not going to get any mast cell that has been primed, so that we will not get any mast cell degradation for us to get leukotrienes and histamines. We can also block the antibodies, all right, using omalizumab, and then we can also block the interleukin 5 pathway so that we will not activate the eosinophils. And agents that are used are mepolizumab, realizumab, and then benralizumab. Okay, so now what if that we also talk about the Lucas and the xylutin agents. These are agents that will tend to block the histamine and the leukotriene pathway. And then I showed it to you when we were talking about the NSAIDs. Lucas drugs, that's Montelukast, they tend to block the receptors of the leukotrienes, while xylutin tend to inhibit the 5-lipoxygenase enzyme. Okay, so this is a summary of what we've talked so far about the agents. We have cromolyn sodium and nicodromel sodium. They prevent mast cell stabilization, and mast cell stabilization is the priming of the mast cell that I talked about. And then interleukin 5 and the antagonists, these ones are the ones that will prevent the activation of eosinophils, that's mepolizumab and the rest. And so we will talk about inhaled corticosteroids, and then we've already mentioned omalizumab, and then we'll visit this when we are done with the video. Okay, so now let's talk about bronchodilators. I told you that the adrenergic system, with respect to the respiratory system, we look at beta 2 receptors. Once the beta 2 receptors are stimulated, there is increased cyclic AMP levels. Now, this cyclic AMP helps in bronchodilation. All right. Once we have increased cyclic AMP levels, we get bronchodilation. So we give agents that will increase the levels of our cyclic AMP as well. Okay, now these beta adrenergic agonists that stimulate the beta 2 receptors are classified into short acting and long acting. And then new blocks, we have the ultra long acting beta 2 agonists. But the ones that I mostly talk about are the short acting and then the long acting. Now, short acting beta 2 agonists comes in these forms. So we have salbutamol, which is what is mostly used, the salbutamol inhaler, also called as a pig inhaler. Then we have the terbutaline also here, and these are short acting. And then we have the long acting ones, salmeterol and then formoterol. And the ultra long acting beta 2 agonists are not specifically used in asthma. They are used in COPD, that's chronic obstructive pulmonary disease management. So we have indicaterol and then vilanterol and oladeterol. Now, one thing I forgot to mention is that the long-acting beta 2 agonists are not supposed to be used alone. Whenever you want to use any of these agents, you have to use them together with an inhaled corticosteroid. That is a new guideline. Okay. Now, the GINA guideline, which is the Global Initiative for Asthma, says that for any stage of asthma, okay, if any person is having an asthma, you have to give an inhaled corticosteroid plus a long-acting beta agonist. Mostly the recommendation is for formoterol, but then in our setting, or maybe in Ghana, mostly we use salbutamol. It used to be salbutamol alone, but now you have to add inhaled corticosteroid to this salbutamol. So whatever agent you want to use, you have to use an inhaled corticosteroid. You start with a low dose, and then you move on to the higher dose when the management is not working. And so the clinical uses is that when you have acute asthma attacks, you want to give short-acting beta agonists, not alone, but with an inhaled corticosteroid as well, and long-acting beta agonists to the same thing like I mentioned. Okay, the adverse effect is that these are beta to adrenergic agents, and adrenergic agents, they are more like the sympathetic agents. And the sympathetic agents, what they do is that they tend to cause your heart to beat faster. That's what they can bind to the beta 1 receptors of the heart, and so they cause tachycardia. Some of them can cause tremors and then hypokalemia if you continue to use them for a very long time. All right. Now, in vets, This is for our vet students. Terbutaline is used in cats for asthma and bronchitis, and there's also clenbuterol that is used in horses, but then they are mostly banned in food animals. Why? Because they tend to stimulate the cardiac receptors, and that will cause a lot of tachycardia. So you don't want to use that too as well. Now, the next agent that we look at is the muscarinic antagonist. Now, the muscarinic blockers are the ones that will tend to block the M3 receptors. And when they block the M3 receptors, what they do is that they tend to cause what? Bronchodilation. Remember from the previous slides that we mentioned that the anticholinergics, or when you talk about the parasympathetic nervous system, they tend to cause what? Bronchoconstriction through the M3 receptors when acetylcholine binds to the receptors. And so we want to block the acetylcholine from binding to these receptors. And we give agents that will bind to the receptors to block the acetylcholine from binding to them. And that will lead to what? Bronchodilation, and also reduce what? Mucus secretion. Okay, and these are also classified into short acting and then long acting. The one that is mostly used, especially in acute asthma attacks, is the ipratropium bromide, which is a short acting muscarinic antagonist. And then we have the long acting ones, eutropium, and then the glycopyrronium, and the others. Alright, so the clinical use that they are the first line agents in COPD, but in asthma, you have to give them together with the beta 2 agonists that we mentioned. And ipratropium, like I mentioned, is the one that is mostly used in acute exacerbations of asthma. We can also use them in rhinitis and postnatal nasal drips. Alright, now because these are anticholinergics, they tend to cause some side effects. And the side effects, they are mostly remembered by the mnemonic dumbbells, okay? But the ones that I captured here is that they tend to cause dry mouth, cough, blurred vision, and then urinary retention, especially in young adults and children. Okay. In vets, they mostly use ipratropium as well in the equine COPD, and it's also used in adjunct in cats bronchitis or asthma as well. Okay, the other drugs that I forgot to mention is the metaxanthin. So when I was talking about the beta 2 agonists, I mentioned that if we have increased levels of cyclic AMP, they tend to cause what? Bronchodilation. And so we have agents that will do that. And these agents are theophylline and aminophylline. Okay, so theophylline and aminophylline are water soluble. You want to remember that for the exams. Alright, they have multi-mechanistic effects in that they are non-selective phosphodiesterase inhibitors. And so when the adenosine receptors are blocked, the beta 2 receptors are blocked, they tend to cause bronchoconstriction and then um, release histamine. And so we want to give these agents that would increase the levels of cyclic AMP. Okay, and so they are used. They are add-on therapies. We never use them alone, and mostly they are not used in practice. But then if you are having some kind of neonatal apnea, then you would want to give theophylline contains caffeine, so you can give, but mostly we give caffeine, and some are also used in chronic bronchitis as well. The adverse effect is that they tend to stimulate the central nervous system, like I mentioned, because they contain caffeine, and so they will lead to insomnia, nervous system, nervousness, and then seizures. And so in the cardiac way, we have tachycardia, arrhythmias. They can also cause nausea and vomiting as well. They are metabolized in the liver and by the liver enzymes, and so they are mostly affected by macrolides and then ciprofloxacin. So you never give them when you are giving these agents to as well, because they will interact. In vets, they are also still used in dogs and cats for chronic bronchitis, in horses, but then you have to use it with caution. Caffeine, like we said, is used in apneic neonatal puppies or kittens. Alright. Then let's come to our corticosteroids. That's the master block behind asthma management. So the corticosteroids, they are the core drugs, like I mentioned, for long-term control of asthma. And what they do not do is that they do not relax the smooth muscles directly, but they suppress airway inflammation. So what they do is that they tend to block almost everything that we've mentioned, right? Mast cell stabilization, inflammatory cytokines, the interleukin 4 and 5 and 13, they block everything so that your airways inflammation will not happen. They also would in turn go and block the phospholipase A2 enzyme that converts what membrane phospholipase to arachidonic acid. And in this case, when that happens, it means you are not producing any leukotrienes as well. So these agents are like, yeah, the ones that we mostly use. So they are the first line management maintenance. You give inhaled corticosteroids together with um, the beta 2 agonist, and then there's the muscarinic antagonist as well. Okay, in persistent asthma, that's what you use. The most common ones that we use as the budesonide and then fluticasone. Budesonide is the one that is mostly used in our setting. And if we have acute exacerbation, you don't want to give inhaled because we want drug that will act faster. So we give systemic corticosteroids like prednisolone and then hydrocortisone. All right. The clinical use, like I said, daily controller in asthma, we add them to the long-acting beta agonist, and new general guideline is saying that we have to also add them to the short-acting beta agonist too as well. And for the systemic corticosteroids, when you have person with status asthmaticus, this is the right agents that you want to use, prednisolone hydrocort, in order to relieve the patient of the symptoms. Right, the adverse effects that these agents tend, because they are corticosteroids, they tend to cause oral candidiasis or thrush. They can cause hoarseness of the voice, and then systemically they can suppress the adrenal system, and so these people would tend to come with what a Cushingoid appearance, so they cause a Cushin syndrome. So you have to take note of that. Osteoporosis, hyperglycemia, and indirectly hypertension and weight gain, they are all seen in the as adverse effects of what corticosteroids. In vets, we mostly use fluticasone via metered dose inhaler (MDI) with spacer mask in feline asthma, and oral prednisolone is also still commonly used in dogs and cats. In horses too as well, you can also give inhaled corticosteroids and then oral dexamethasone in flare-ups. Then the next ones, I've already mentioned the leukotriene modifiers. I mentioned that the one that inhibits the 5-lipoxygenase enzyme is what? Xylutine. And then we have the ones that will block the receptors, that's montelukast and zafilukast. And these drugs are used in mild persistent asthma. If there's an aspirin sensitive asthma, you want to give these agents. All right. And because they have adverse effects, the adverse effects are the headache and GI discomfort. Xylutine tend to cause hepatotoxicity. It's not good for your liver at all. Alright, some of them too can come with neuropsychiatric symptoms like agitation, depression, and suicidal thoughts. Now, montelukast has been explored experimentally in canine atopic dermatitis and feline asthma, but then there's no data to support that, so they are not using vets as well. The last agents that we talk about are the monoclonal antibodies in asthma management. Omalizumab, like I said, is an anti-IgE, so it blocks the IgE antibody, and that is going to prevent the mast cells from being sensitized or being primed, and so that would decrease the levels of leukotrienes and histamines, and in turn we get the effects that we need. I also mentioned that so this is like the interleukin 4 and 13 pathway. We have mepolizumab, reslizumab, and benralizumab. That one too, I mentioned that they block the interleukin 5 pathway, and so they are used in severe eosinophilic asthma as well. The side effects are headache, injection site pain, and hypersensitivity reactions as well. We have a new a new agent, the dupilumab, also blocks the IL-4, IL-13 pathway as well, like that of the omalizumab. Okay, but then one thing you have to take note is that these agents are not routinely used. They are reserved for severe refractory asthma, and they are all injectables. You have to give them IV. All right. Now, in vets, but we don't mostly use these enzymes. These agents are not used. There's experimental use in canine atopic dermatitis, like the agents we mentioned previously, but then they are not used in vet med. Yeah. Yeah, the mast cell stabilizers. We want to prevent the degranulation of mast cells, and so you can give cromolyn sodium and nicodromel sodium, like we mentioned. And these are used in as a prophylaxis for asthma, especially in exercise-induced asthma. Yes, exercise too can cause asthma. Yeah, and we have allergic rhinitis, allergic conjunctivitis, and then food allergies. They are not preferred in the GINA guideline due to their lower efficacy compared to what the inhaled corticosteroids. So like I want to mention and I want to emphasize that inhaled corticosteroids must be used. Alright, these mast cell stabilizers tend to cause cough, throat irritation. They have a very unpleasant taste, especially with nicodromel, sorry, and they tend to cause bronchospasm and then dermatitis. Occasionally, we use cromolyn in feline asthma. All right, yeah. So, like I said, this is a summary. We've already mentioned that cromolyn sodium and nicodromyl sodium, they are used as mast cell stabilizers. And then these are interleukin 5 antagonists, mepolizumab, reslizumab, and the others. They tend to decrease eosinophil activation and recruitment. You want to memorize this table. It will really help you with your exams. So we have inhaled corticosteroids. They suppress almost everything. Omalizumab, anti-IgE, leukotriene receptor antagonist, montelukast and xavilucas. We say they block the receptors, diluting, they block the enzyme. Short-acting beta-2 agonists, they cause bronchodilation. Long-acting, the same thing. Ipratropium, that's anti-muscarinic intent, that's going to cause bronchodilation. Then theophylline 2, we said, is a phosphodiesterase inhibitor, so it tends to increase the cyclic AMP levels. And when we have a lot of cyclic AMPs, that will tend to also cause what bronchodilation.